Alright, so we're going to take a quick look at the arterial supply of the foot as a whole. As a quick run through, coming off of our common iliac, we have our internal and external iliac arteries that are going to run down the leg and turn into our femoral. Our femoral will have a branch known as the profundus or the deep femoral. And pretty much though, as we go down and go down, our femoral artery is going to supply all of our genicular branches, our popliteal branches. Anteriorly, we'll have our anterior tibial artery, and then posteriorly, our posterior tibial. Oh, here we go. Yes, our femoral changes names to popliteal in our popliteal region. And then we have the split right after the popliteal region. Here's our peroneal artery as well. Pretty much the main one that you'll need to pay attention to again is this dorsalis pedis coming off of the anterior tibial artery and also supplying the dorsal arch. Along the bottom of the foot, we have the lateral plantar, the medial plantar, and then the plantar arch supplying that as well. Okay, so this is, again, just general layout. You should already have seen these and been very familiar with this arterial supply. As we look closer at the plantar surface of the foot, the lateral plantar artery, so remember all of the tiny little muscles that are on the lateral side being supplied by that, and then the medial plantar artery more over the medial column of our foot and medial longitudinal arch. These come off of a branch of the calcaneal branch of the posterior tibial artery, but pretty much knowing that the bottom of your foot, like right here, is going to be supplied by the posterior tibial artery, and then the anterior or the dorsum of the foot from the dorsalis pedis artery will be supplied by the anterior tibial. Okay, so if we trace both of these back, the anterior and posterior tibial are branches of our popliteal, which is a branch of our femoral, and so on and so forth. Okay. Alright, I thought this was a cool picture. So what they did in this cadaver is they took all of the blood out and then replaced it with a plastic fixative so that whenever the actual walls of the artery were removed, this was intact. I believe that's what they did. I've seen a few other pictures like these for like the lungs and other stuff, but yes, I believe a plastic fixative was put in here so that you can see right here the dorsal arterial arch on the top of the foot. Alright, so let's look at the venous return. Again, the femoral vein gives branch to the great saphenous vein right here that travels all along. And we have a few splits and branches, but long story short, we have our dorsal venous arch. One thing about these arches in the foot is that they can give us an inclination of the hydration levels in our patients. So if you can look on the tops of people's hands, remember we have the arches on the top of our hands too, and then on the feet as well. Being able to look and see if there's any rise to these veins, then we know that they are getting somewhat enough hydration. You know, we are not able to diagnose their hydration status, but it is an indication as to how much they've had or their salt or sodium intake, things like that. So just something to take a look at. Again, this is not the case for everyone. Some people that are a little bit overweight, it would be much more difficult to see this venous arch. Additionally, everyone's different. Veins are tortuous and never have the exact same pathway, so each of them vary from person to person. Okay, so the last thing we're going to do is look at the general innervation to the lower limb. Sorry, this picture is a little blurry, but pretty much off of our sciatic nerve, we know that the sciatic nerve is just the combination of the tibial and fibular nerve, but it's running together. So our tibial nerve continues down and pretty much terminates as the medial plantar nerve and then the lateral plantar nerve. So listed here we have what each one supplies. So our medial one is going to do our abductor hallucis, our flexor digitorum brevis, and our flexor hallucis brevis. And then the lateral plantar is going to do the remainder. We'll discuss the rest of these nerves whenever we move more proximally to the next section. However, I do want to point out your dermatome map. Again, be sure you know this dermatome map, especially when it comes to neuro, the class you're taking now. Pretty much whenever you have different spinal cord injuries, then sensation, musculature, different things are affected by how the spinal cord is injured. So, for example, if an injury occurs just at the dorsal side of the spinal cord, we know that the dorsal region in the posterior funiculus holds all of our sensation. So, if we have a severance of the posterior, then we may have sensation along this side, but no sensation along the other side, or we might just have particular sensation. So we might be able to feel vibration and discriminative touch, but we might not be able to feel temperature or things like that. So just be aware of how this map is laid out, because if you have a patient with an L4, L5 spinal cord injury, what can they feel? What do you need to be made more aware of? Does that mean that they can feel the bottom of their foot? So when you ask them how their ankle foot orthosis feels on their toes, will they know or not? So you need to know this general layout and how different spinal cord segments occur. So again, a dermatome talks about the pattern of skin that only covers a section from one spinal cord level. So this area is just from L3. This area is just from L5. Okay, pay attention to the bottom. We have S1 covering majority of the bottom of the foot and L5 on the other half. All right, let's compare this to our cutaneous map. So our cutaneous map, remember, is not the same as our dermatome map. Our dermatome, again, comes from one spinal cord level, whereas the cutaneous come from 2 to 3 spinal cord levels. So this one's going to be a little bit different. Loss of sensation in these areas are going to be from a more peripheral injury, typically. So if you have sensation loss in this particular pattern of, let's say, the saphenous medial crural nerve, then you are going to have it due to more than likely it being cut along its pathway rather than a spinal cord injury. So the display of how sensation is lost will be based upon the pattern. So again, right here, say if this is cut in surgery or something else, then this particular pattern would occur of numbness or loss of sensation, whereas if we had an L3 injury, it would be similar, but not exactly the same. Okay. All right. Now, and you can see how there's a little bit of differentiation between this map and this map. Again, everyone is different, but these are going to be the two most common ones seen. So I am particularly aware of these first two and have learned these first two in my studies. So